Welcome to our first series of our Palliative Pearls podcast. My name is Rachel Fawcett and my co-host is
Leanne Hobson.
And we are clinical educators within South Tees NHS Trust. We will be inviting guest speakers to join us to share their pearls of wisdom on all topics related to palliative and end-of-life care. And I am delighted to invite today's first guest speaker, Julie Lamb, who is lead nurse for cancer and palliative care within South Tees NHS Hospitals Trust. Welcome, Julie.
Thank you for inviting me.
Can we start by asking if you can tell us a little bit about yourself and your career to date?
It depends how long you've got, really. I started my training in 1986 and trained in Newcastle. After qualifying, I worked in cardiothoracic surgery, usually primarily with lung cancer patients. And then after that, I moved to Gateshead Trust and worked in breast care, looking after patients after breast care surgery. So that was where I started my career, really looking after cancer patients. After that, I'd started to think about what happened to them after they'd been in hospital and had surgery, what happened next. And that led me to go down a district nursing route. So I worked in district nursing from 1996 to 2002. After that, I started to spread my wings into specialist palliative care and work as a specialist palliative care nurse in the hospital, community and in the hospice. And then after that, after many years in specialist palliative care, I then decided that I wanted some wider experience, and that was when I started working as a lead nurse. So I worked as a lead nurse in cancer and palliative care in Gateshead, and then after a couple of years, I came down the A19 to South Tees, and I've been here for the last 3 years.
Julie, I'd be curious to know what made you first want to go into palliative and end-of-life care?
I can pinpoint it exactly. I was on the breast care ward. I was working with a lady who was very unwell, had a lot of palliative care needs. I was a staff nurse. I'd looked after her well, I really hoped, and I'd known this lady for quite a period of time. And one day we referred her to the palliative care nurse. They were very new when I first started. There were new roles, cancer nurse specialists. And the nurse came on the ward and took me with her to see the patient. And she did the most fabulous assessment. So she did an assessment of the patient. She examined her. She sorted out our pain control, and she listened to the patient, which is all I can say, really. And in that 20 minutes of that intervention, she knew more about that lady than I had for looking after that lady for years. And that approach was so compassionate. Our communication skills were superb. And I looked at her and I thought, I want to be you. I want to be as good as you are. So after we came out of the consultation, I said to her, how do I get to that? What do I need to do to be as good as you? So she was the one that set me on the path of specialist palliative care. And I can, pinpoint it to the day of when that happened.
I think we all have that one person.
Yeah.
And I certainly can think of 2 or 3 people in my career where I've thought, I want to be you because you give the best care that I've ever seen.
And I think for me it was our communication skills were excellent, but also it was that clinical knowledge and the expertise that you had, that you could answer questions about the patient's pain. She gave information to doctors about what to prescribe, and she was just provided such holistic care that I thought, I need to learn that. I need to be as good as you are.
I wanted to be that nurse that really knew her patients.
Yeah. And I thought that I was. Yeah. But really, when I looked back, I had looked after that lady for months, on and off. She'd been backwards and forwards into the ward, and I didn't get that information that specialist got. In 20-30 minutes, she knew so much more about what was important to that lady than I ever did. And so it made me realise that sometimes you think that you're doing a good job, but actually there's always more to do.
So Julie, you've talked there a little bit about why you wanted to specialise in palliative and end-of-life care and give a a beautiful example, really, of the importance of that holistic assessment and really getting to know your patients. And it's a very specialist area, and I know it's something that you're very passionate about. But in terms of what are the skills and how can we make sure that that's available to the wider organisation, and that palliative care really is everybody's business. So how can we make sure that not everyone will have that high level of specialist knowledge, but how can we make sure everyone's got some skills?
And I think everybody doesn't have to have that high level of specialist knowledge, but what we have to make sure is that everybody has got some general experience in caring for a dying patient. And like I've said, I first got interested in specialist palliative care and knew that I wanted to be a specialist palliative care nurse when I worked on an acute ward. But then I went into the community. I wanted to see actually what happened to these patients in the community as well. And there you see that actually generalist palliative care is just the community nurse's bread and butter. And what I wanted to be able to see and make sure was, did we make sure that everybody who was working in the community, but everybody who was living and dying in the community had a good level of generalist care. And when my children were little, I worked in the out-of-hours area. Used to be called the out-of-hours district nursing service. It would be the out-of-hours specialist palliative care team now. And I just looked after patients all evening who were in the last days of their life. And it showed you really how important it was to have made sure that you had really proactive planning for these patients, that everybody understood what symptoms they might have in the last days of life and actually had the confidence to treat them. And I think that's really where I've come from now, and I've spent a little bit of time in an education role as well, working as a senior lecturer in palliative care. And my big focus on that was not to teach everybody to be specialist palliative care nurses, but to teach everybody to have the confidence to be able to look after a dying patient in the months before and planning up to that, but also in those last days of life, so that people felt confident to care for them. And I think that's really what we have to achieve. We don't want to achieve, well, it'd be lovely, but we would never have the resources to have everyone trained to a specialist palliative care level. But we need to make sure that everybody has the confidence to care for a dying patient, because with certainty it is the only thing that, none of us are getting out of here alive. 100% of us are going to die. We hope that it's a long time off and that we have a really good, healthy life. But we have to be prepared when it does happen. And I think my biggest bugbear when you're talking about palliative care being and end-of-life care being everybody's business is that people don't think it is their business. People think, oh, that's not for me. I need to get the palliative care nurse involved in that. When actually, if the patient's known you for sometimes years in the community, or you've been that nurse who's caring for them on the ward, it's you that they want to speak to. And I'm saying there about nurses, but actually it could be an occupational therapist, it could be a physio. We all know that there's sometimes when you're being cared for, there's some of the healthcare professional staff that you will gravitate to, and those people need to have the confidence to have a conversation with you about what's important in your last days and in your end of life.
Yeah, I think you summed that up really well. Thank you.
I think you probably get something that I feel really strongly about. I think that we absolutely need to plan. If you think about it, when we have children, we go to see the midwife and we talk about the birth plan and we talk about what we might want to happen and what we don't want to happen. And sometimes it all goes to pot. But actually, at least somebody has had that conversation with you. And we need to make sure that we are brave enough to have those important conversations with our patients.
Yeah.
Following on from that, Julie, we live in a world now where talking about death and dying is difficult for a lot of people, and I feel we've probably moved away from it, especially from when I was young. I had grandparents that would talk quite freely about death and dying, and it wasn't something that I grew up being frightened of. But we live now in a culture of nurses where people are frightened to approach that. Have you got any tips for our staff to talk about death and dying?
I think that there's a couple of things really from that. From a society perspective, we are really uncomfortable about talking about death and dying. If you think about when you see it on the telly, you never see a patient who's dying as how we would see patients with secretions and difficult things like that. You never see that on the telly. There's usually something absolutely acute happening. So I think we need to make sure that we encourage people to talk about it. I think we have to also make sure that people realise that just because you're talking about it, it doesn't mean it's going to happen. I think if we think about how many times we talk about weight loss and diets, but it doesn't mean just because we talk about weight loss and diet that suddenly we'll lose weight. So I think we have to be really key with people to make sure that they understand that talking about it doesn't make it come any quicker. It just means you're prepared. And what we also have to think is that we need to reframe. We often talk about having difficult conversations, and if you read textbooks, they'll talk about difficult conversations, and we need to reframe that to being important conversations, because that makes us have the impetus that actually it's important and we need to speak about it. And as in thinking about having the courage to be able to talk about it and to be able to bring it up with patients, I think it's just thinking about actually, if you were in their shoes, what would you want? What would you want to be able to have that conversation with? Which healthcare professional would you want to have that conversation with? Who would that be? And what might those things be? And think about what you might want to be able to think about how you talk to a patient. The other thing I think is that people always think, I'm frightened to have a conversation because I might upset the person. I might say something wrong. And what I would say is be courageous. You might upset the patient, but actually at least you're showing that they matter. And that is really important in healthcare, that the patient knows that they matter to us and that we're interested in them. And I also think that patients are really forgiven, that often you might say something wrong, you might say the wrong thing, but if you approach that in a compassionate, caring manner, you've said something wrong. But I've often found in my career that I've said something wrong, and then I've said, I'm really sorry, that came out the wrong way. That's not what I meant to say. And I've had another go. And usually you find that patients are really forgiven, and they will just recognise that it's difficult for you as well. So my answer would be courageous and don't be put off, and think about it as an important conversation.
Some of my things around it are, you're not making the situation worse. It's already a bad situation.
It's already awful.
Yeah. Mm-hmm. And if you are able to then bring that conversation to light and talk about it, can often make the journey forward a bit easier than not knowing.
Mm-hmm. And it might be that when you raise that conversation, that the patient might feel that they're not ready to have that conversation, but at least you've offered it to them, and at least they know they can come back and ask you again.
We've talked a little bit there about having courageous conversations. What piece of advice would you give someone who wanted to follow in your footsteps?
I think a couple of pieces of advice would be really find your role models. Find that nurse that I talked about when I worked in breast care. Find your role models, watch them and learn from them, and spend time within specialist palliative care and work with the team. But I think the other thing is really important is actually getting wider experience. So don't just suddenly think, right, okay, I'm a staff nurse on a ward and I want to be in specialist palliative care. Get some different experiences, work on a surgical ward, work on a medical ward, oncology day units, chemotherapy units, and the community. Remember that palliative care patients are across all of those aspects of care. So go spend a bit of time going to other places. And I think I learned my skills. I knew where I wanted to be, but I learned my skills as a district nurse, and particularly in those out of hours areas when I was caring for patients in the last days of life. And you didn't have any contact. Everybody's at home, usually in bed, and you have to make those decisions yourself. And I think that's really a good place to start. So in a nutshell, a broad experience and then focusing on specialist palliative care.
Yeah, I would have to agree, because you don't really, wherever you work, you're always going to meet someone potentially in their last year of life, in whichever area you work in, and I think those experiences look valid.
Yeah, definitely.
Julie, we've talked there about following in your footsteps and what piece of advice you might give them, but whilst you don't look old enough to retire, I know it's something that's looming on the horizon. So, I suppose really what I want to ask is, what's next for you?
Well, thank you for saying I don't look old enough to retire. I think it's just a good foundation. Underneath here is some wrinkles and rags. What's next for me is always still having an interest in specialist palliative care, and I think I will always be a nurse through and through. But I recognise that this time is now some time for me to have some fun. And I've always had fun, but just time for me and my husband and our adult children to enjoy a bit of rest. So I think I will be spending quite a bit of time on the beach with my 2 cockapoo dogs, and just enjoying.
Fantastic. Well, certainly from our point of view as an organisation, you will be greatly missed. But obviously, thank you for the fantastic service that you've done, and we wish you well with that. So, for our final question, really, of today's podcast, I just want to ask, what would a good death actually mean to you?
So, if I was thinking of a good death, for me, ideally, I would like to be old, certainly older than I am now. I do remember asking a medical student what he thought would be a good death, and he told me being old. And when I said to him, what's old? He did say about 50, which was a bit of a worry. But to me, a good death for me would be that I knew it was coming, that it would give me an opportunity to spend time with my children. Tell them, I always tell my children and my husband how important they are to me, but it would be able to be given time to make sure that they knew. I would want to make sure that, well, firstly, that they knew how to make a decent gravy for the Sunday dinner, and also just having an opportunity to say goodbye to people, and also an opportunity to make sure that I'd had a conversation with people. And for me, a good death would be at home, in my own bed, having been cuddled by my husband with my girls around me would be my good death.
Thank you for sharing that too. It's been a pleasure talking to you today.
Thank you. I've enjoyed it.